So hi, Alan. It's Sunday again.
Morning,
That's why,
Andy.
that's why I'm wearing a sweatshirt. But we talked a little before all this started. But it's been a rough couple weeks for me after a rough couple years in primary care. And Alan and I, you know, we wrote Return to Healing in a lot of ways to try to show what the problem was in healthcare. Despite even this new administration that has said a lot of crazy stuff, but has also promised to help primary care, to help move us in a direction more of wellness rather than sick care, nothing's happened. I mean, if anything, things are getting worse. And I was telling Alan that, in my world, I work both in an office and in long-term care facilities with elderly people. And a lot of what keeps us going there is what's called a medical director fee, which isn't that much, but it's enough to cover some of the stuff we are required to do without getting paid for. And all these places are just dropping that. They want me to do all the medical director stuff. The threat is if I don't, they will bring in another group, a group of nurse practitioners, a group that's run by a big corporation that exists in Virginia that's trying to sell health insurance and using these facilities to make money. My friend Andreas, who you trained, who's a great geriatric doctor, he's in facilities that are being taken over by nurse practitioners and nurse practitioners pretending to be specialists. So basically, they're coming in as kidney doctors and heart doctors and basically using the patients to make more money, but kicking him out. Here's a guy who's got 30 years of geriatric experience, who's certified as a medical director, who has common sense, who understands that 90-year-old people with dementia should not be on high dose statins, and people who are bleeding should not be on blood thinners. But these guys don't see the world that way. They see the world as this is a place to medicate, test, treat everyone, to be what they call thorough. And our world is just, it seems to me at least, Alan, our world is becoming untenable.
I
Even me.
think it's imploding, Andy. You said it all. We got a sick care system, and the system is sick. And there's really no huge incentive to try and improve it for many people, except us, the primary care physicians. And it really should be the political folks. But the cost of healthcare keeps rising. We're up to over $15,000 per person in this country per year. That's more than double the next leading nation. We're like number 38 or 40 in survivability. Our equity statistics are horrible. Like there's nothing good, and we have a very low quality, high cost system that is based on doing things to people rather than for them. It's about doing procedures. So yeah, if you have a heart attack or a stroke, you're more likely to be saved in this country than anywhere else because we have the greatest toys in interventional cardiology and interventional neurology. But we do absolutely nothing to prevent stuff, and we don't really care about it, it seems. So, like in your situation in the nursing home, I love nurse practitioners. I have a nurse practitioner in my practice. I hire multiple nurse practitioners that work with us in the hospital, but they work as a team with us. They don't I don't see them as independent practitioners, which many states do. Some of them have 600 or 700 hours of training compared to our like 30,000 hours of training that we've had. And they want to hand your homes over to them. You know what's going to happen? They're going to order more stuff and they're going to send them to the hospital more, which is going to end up costing more. So it's this vicious cycle. It's the hamster wheel. You keep running at it. The costs keep going up. The reimbursements go down. Like I joke, this is my joke. I've been practicing for 39 years now, 39. And when I first went into private practice, everybody got the same bill for a new office visit of $125 and a follow-up was like 90 or something like that. We send like those same bills now. Back then, we got 80% of what we billed, and the insurance company or the patient paid 20%. Now we get like $36 for that same visit 39 years later. Just that says how the system is untenable for primary care.
Yeah, and I'm in the same situation. In our office, without these extra payments, I mean, we will sink. I mean, I all I have is this office practice. I remember when I went into this 18 years ago, and I've been practicing for 35 years, but I've been on my own for 18. Everyone said you cannot succeed as in a primary care practice on your own. It's just not possible. I said, I'm going to prove you wrong, and I'm going to have 30-minute visits, and I'm going to have a health education room, and I'm going to have meetings and newsletter. I went in there with the passion that drove me into healthcare, that I was going to do it. But, 18 years later, the reimbursement is barely different from what it was. Nothing's gone up. But the cost of running a practice has doubled and tripled in the last few years to the point where our overhead is now approaching being as high as our revenue. And that's really scary because we can't pay anyone if that's the case. We have to see more and more people is the only way we can deal with it. And that means my dream of actually being able to sit down with a person and talk to them, which is primary care, relationship medicine, having enough time to understand the person in front of you and letting them talk instead of you barking at them all the things they're supposed to do. That's becoming untenable. And that's what I love about it. I want to talk to people about their diet and their life and their causes of depression, and I want to talk to them about really should they be on these statins and be on this Eliquis. Let's talk about it. It's almost as though they don't want us to talk about it,
And,
Alan. That's the
and
way
it,
I feel.
yeah, and there's been a huge generational shift. Most of us went into medicine because, it really was altruistic. It's a calling. I want to help people. I want to save the world. Yeah, I want to make money. I want to support my family. I want to have a good life. I want to be able to go on a vacation, which I haven't for years now, because I am a solo practitioner in my faculty practice. But the generational shift of like a lack of respect for your fellow human being is really coming down hard on medicine. Like, there's violence in the healthcare system now. Like you tell people like, you can't see me today. What do you mean? You're my doctor. Like I need to be seen. Well, I have 30 patients scheduled for the day. And like you're calling it 2 in the afternoon and like, but people feel like they're entitled that we've become their employees. Well, I pay for my insurance and you have to see me, and you get nothing. Like I can't tell you how many times I get yelled at by patients now. Like I've never terminated patients in my career until recently when some of my staff like got like scared about some of these yelling from the patients and things. It's totally changed. Like from Marcus Welby MD, the respected doctor, coming to your home with a bag to you're going to do what I say, or I'm walking with my feet, which people are entitled to do, but it's not greener on the other end, especially in primary care.
Yeah, I mean, I agree that the internet is certainly part of the problem. The absolute explosion of specialty care, and in our world, by the way, that specialty care is carried out by nurse practitioners who don't have any more training than my nurse practitioners I work with, who are primary care nurse practitioners, very good, geriatric trained, understand. We work as a team, and by doing so, we kind of reduce hospitalizations. They're all on board with cutting back medicines, but not these nurse practitioners in specialty care. I had a patient, Alan. It's a couple. They're wonderful people, but they're late 70s, and she's having some memory problems, but it doesn't seem that serious. I thought a lot of it was anxiety, but they decide to go to a neurologist who specializes in this, and they see a nurse practitioner. That's who's there, who orders, and I calculated it was over $10,000 of testing, including various amyloid tests, a PET scan, things that I explained to him, to the husband, are not helpful. We don't know what amyloid means. We don't have any idea. We do know the one drug to treat amyloid, which is $50,000 a year, causes massive amounts of brain bleeds and also does not improve memory at all. So maybe the amyloid's there for a reason. But why are we testing a PET scan? He says, well, we need to know if she has Alzheimer's. I said, there's no evidence that a PET
Yeah.
scan can tell you that. It's just money, 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 money.
Yeah, the average cost apparently of giving that drug is well over 100,000 with the scanning and the repeat scanning that's needed. And there's some data somewhere that it increases like one functional ability thing or an ADL or something silly that doesn't even work. But now you hit my nerve with the specialist because I go through it a lot because I have this dichotomy at my work. So, I am the chair of an ambulatory care network that has extensive primary care. So those people actually listen to me and respond, but we have full multi-specialists that go through our clinics. And like you said, all of them have an NP now. And they say, well, we'll see the initial consults. And then the NP could take it on from there. So I look at them and say, oh, so you're going to do the initial consult and give your recommendations. And then you're going to keep the patient, keep bringing the money in with your NP seeing the patient, and they know more than me. And the guy looks at me and he's like, no, I didn't mean that. I didn't mean that the NP knows more than you. It's just like you sent them to us, so we're going to manage. So now that they have the patient that they really didn't want in the first place, they just have the NPs doing the visits after that. So what do I need that for? Give me your opinion, send them back, and move on. But it's inferior medical care. They don't have the training that is required. And again, I don't, I hope there's plenty of NPs listening to this now. I love our NPs, but I've trained my ones that work for me. I supervise the ones. I don't know if you do it, Andy, but I countersign every one of my charts. So this is my first weekend off in a month. I take one Saturday off, the 4th of every month. I work every other Saturday. And Sunday morning, I sit at my computer and review the notes from my NP yesterday, who, saw a substantial number of patients. And sometimes I'm getting on the phone and either with my NP, or with the patient because something's not clear in the note. And every week I pick up something, and she's fabulous. I trained her. She's trained in geriatrics and hospice and palliative medicine, and I trained her in primary care. So she's got tremendous hours of experience, but it's not our experience from doing this for 40 years and receiving a level of training. Like some of those basic skills are important, and they do no basic skills. It's just continues to add to the cost of our healthcare system.
And yeah, I feel like when you're dealing with a nurse practitioner in specialty care, they are not trained. And they don't know as much as we do about that very organ that they are being consulted on. Look, I don't need a lot of specialists. I don't. But every now and then I want to ask them a question, um, or I can't do a certain procedure that only they could do. But I don't want them to keep the patient. That's not my intention. The way the world used to work when it was more functional is 80% of doctors were primary care, and the specialists were there to answer questions or to do procedures. And then once they were done with that task, they sent them back to the primary care doctor. By the way, Alan, not only do I wake up every morning with 15 messages that hit me overnight, and that they continue throughout the day. People want free care all the time. But a lot of my messages are, well, the cardiologist started me on this drug and they said to get in touch with you. I mean,
Yes.
what's that all
Yeah, I wouldn't take any drug if you don't say it's okay. Like I get that
about?
all the time.
And
And I
it's
said, well, did you ask the cardiologist that you went to without me telling you to go? I don't know why you're seeing a cardiologist. Why did you go?
exactly. Now they're having problems. By the way, or the cardiologist, like if they have pain from their statins, they'll send them to an orthopedist
Yeah.
or a
So
rheumatologist.
so I get, my faculty practice, like I said, has every specialty. Like it's a multi-specialty that's part of it. So it's doctors that I work with, and for the most part, I trust them. And when they overdo or over refer, I have no problem telling them. And they say, you know what, you're right. I'm sorry. So like my nephrologist, couldn't find anything wrong with this person's kidney. So he sent them to his colleague, the rheumatologist. So like I called him up. I was like, why did you do that? Like, what's your indication? And he's like looking, oh, I'm not really sure. I just didn't find anything wrong. I said, so send them back to me and say the kidneys seem okay. So you can't make this stuff up. So I'm getting texted now. I'm gonna diss my NP. Okay. I'm sorry. I'm sorry, Jing. Her name is Jing. She's lovely. So she goes, I just finished my notes from yesterday. I'm sorry I was late, you know, but I saw a 44-year-old with sinusitis and coming into the office, her blood pressure was high at 150 over 100. But when I just looked at her note, I forgot to recheck it. I'm sorry. What should I do?
I mean, not that bad, the blood pressure.
I said, tell her to go to, I said, well, yes, you need to call the patient, tell her to go on a low salt diet, and she needs to follow up her blood pressure. But like they, they panic because they have such limited, you know, knowledge of how you handle something like that, or, the idiosyncrasies of medicine. But, if people don't get a sense we're angry, we're angry. I think, before we finish, we should expect at least 5 minutes talking about how we think we could fix it. We do that in Return to Healing. We talk about how effed up the healthcare system is, and it's very effed up. If you haven't read our book, you should, because it talks really, I think it's great. I'm not just saying that because we did it, but every one of my patients and friends and colleagues at work who have read it said it really walks through the history of medicine and how we got to this mess. And you don't leave us hanging. You give us simple steps to fix it.
Yeah, we do. We do. I gave a talk at University of Maryland to a bunch of pre-meds because I had taught a course on the history of medicine. And one of my students asked me to give a talk to this group of pre-meds. And at the end, one of them said, I don't understand why this isn't a mandatory part of our curriculum. And it should be. Doctors should know where we came from. But even more importantly, people who use the healthcare system should know where it came from to understand the motivations that are driving really horrific care that is being sold to us as necessary and effective. Half of our healthcare system is basically making its money by cleaning up the messes caused by this over aggressive care. Even the blood pressure 150 you mentioned, I'm like, okay, so my own view doing this 35 years, 150 on one day when you're sick. I mean, who cares? I just don't even care about it. But I would probably say, yeah, we'll see what it is next time.
But
And
that's the thing. They don't understand the intricacies of what is that important and critical and what's
right,
not.
exactly.
Therefore, if she didn't have me, she'd probably be sending this patient to a cardiologist
Right,
or
and that's
something
the
like that.
problem. Right, that is
Right.
the problem. And not having well-trained, experienced primary care. I feel like after 35 years, Alan, as my friend Andrea says, the more we go, the more we realize how much we don't know.
Yeah,
But
because it changes every day.
it changes, and we also realize a lot of our assumptions are wrong.
Yeah.
But also we have the comfort of knowing when to leave things alone, not care, say don't worry about it. We have that comfort, which I feel really good about now. I don't get nervous actually when I walk away from a patient encounter. I feel like yeah, I've
Yeah.
gotten decent
Well,
at this point.
so like you were saying about that, like we've learned in medicine, well, not most doctors, but Andy and docs like us, that, more than 50% of what we've learned is absolutely wrong. And then the outside world criticizes the healthcare system because they say when a proven change comes along, it takes the average doctor like 10 to 15 years to change their habits in doing that. And I was like, those are the doctors that are smart because they're not relying on new unvalidated data that hasn't been replicated.
Exactly. We're also relying on our experience, which means a lot. As an example, they've told my father. I have a friend whose dad has lost his vision in one eye from bleeding, and yeah, this week, a couple days ago, had a bleed in the other eye, and he's on Coumadin, and they don't want him to stop it because he'll get a stroke from fibrillation. Okay, Alan, my
Let's bleed
experience.
in his other eye so he
Yeah,
doesn't see
yeah,
anything
yeah.
now.
Don't worry. I've had hundreds of my patients with fibrillation not take blood thinners. I cannot think of one person who's gotten a stroke, and that's my experience. Is that this deception that's being sold to patients doesn't actually exist. It's like where I'm seeing damage from blood thinners every single day. I see
Right.
that, but I
Those are
don't
the
get
strokes we see, the
those are
bleeds.
the strokes I see. I see them from the blood thinner. But you can't convince anyone of this because the specialist has spoken. And God knows, Alan, they have 3 years of extra training in cardiology that we don't have. How do they not know this? How do they not know the physiology of heart attacks, which they don't? They just feel treating numbers is what's important. open up blood vessels that are blocked, even though we know that doesn't work. I mean, it drives me crazy every day. So how do we fix it? We both added to that section. So why don't you?
So I think number one, and I'm just going to put my neck out there for many colleagues in medicine. I don't think the system is really fixable the way it is. Like, there's got to be a substantial shift to primary care, number one. And we need to blow up the medical industrial complex. That's the only way we're going to fix it. So, for folks who don't know what the medical industrial complex is, it's the big pharmaceutical industries and device makers that are just raping our system. It's the healthcare industry that's raping our system. It's big academic hospital systems and for-profit hospital systems that are raping the system. We say time and time again, a report just came out from the Milbank Foundation. They put it out every year. And every year we've gone from, 20, 30 years ago, spending like 50% of our spend on primary care. And in most states now, it's like 3 to 5% of the healthcare dollar is spent in primary care. We need to blow it up. And unfortunately, another major part of the healthcare medical industrial complex is our specialty colleges. Those people that represent the cardiologist and the neurologist and the surgeons. And they have huge lobby groups and they don't want to see the system change because those are the people making millions of dollars while we're struggling to keep our practices alive. Like, if it doesn't change and it doesn't change soon, you're looking at two dinosaurs right now.
Two dinosaurs, because no one goes into what we do, and we are actually what I would call thinking doctors too. It's not just our training, but we're skeptical. We're critically thinking. We look up things independently of what we're told we should do. You know, all these protocols and stuff. A lot of doctors are just very robotic about following it, and as we show in Return to Healing, a lot of them are completely wrong. They're designed by drug companies to get you to use stuff. So we are dinosaurs. So what needs to happen is that a shift in payment has to occur. And it doesn't have to be actually a huge shift. It's interesting that well, one of the guys in the administration, in the Kennedy group, tried to pass a bill to cut 4% out of procedural care and redistribute it to primary care. And it failed. It got lobbied to
And
death.
that 4% would
4%.
probably equal 15% for primary care.
Exactly. It'd be
And it would
15%.
change the healthcare system. It
Yeah.
really would. Like, everything I see in this world just gets me so angry. So I don't watch a lot of TV, but I was off yesterday, so I caught up with my work, and unfortunately I watched the Iran war like live on
Oh,
TV.
God, help us.
Well, every time there's a commercial, it's about a very expensive drug, but this one really got me. I don't know if you've seen this yet, Andy, but there's a new ad out sponsored by the AMA, the American Medical Association, the Ad Council, and one other group, I forget what it was, about prediabetes, a new and very dangerous disease.
Oh my
If
God.
it's 1/3 of our population has prediabetes, it's a dangerous disease, and 80% of them don't know they have it. You need to go out and get tested for prediabetes today, because if you don't fix it, you're going to die from diabetes. Like, it's like, holy cow, how can they put that on television?
Those are-
And and when you look at the thing between the people that are diabetic and the people that are pre-diabetic, it's 80% of our population. So we're all
80%.
dying. We're all dying,
80%.
folks. Hang it up now. Don't even go to work tomorrow because you're a dead person.
No wonder we have a diabetic epidemic because it was invented. But no one. And by the way, no one's going to talk about food and diet and all these other things that. But yeah, prediabetes. We talk about it in our book. There's overt evidence that it was invented by drug companies and by specialists. Overt evidence. We have it. We have the articles in there. It is not, and we wrote an article in the American Family Physician about prediabetes that is not predictive of anything, actually.
Okay.
It's only predictive of you taking more medicines and seeing more specialists and getting more tests. That's what's going to happen from this phantom diagnosis. But that's the difference between a critically thinking doctor and a doctor who simply, because a lot of my doctor colleagues believe in this, and they get panicky. Oh my God, there's prediabetes. I'm like, yeah, I have pre-death. I mean, so you're going to cure me? We all have pre-everything.
Yeah, well, again,
Actually,
we've said this before on our podcast, you're not allowed to die from getting old in this country. Like you cannot put on a death certificate, you know, being old. It's not allowed.
doesn't matter how old you
Yeah.
are. Yeah. And so that brings up number two. And we talked about that we have to change the payment system. So frankly, primary care doctors have more time with their patients and make the same amount of money as specialists because honestly, our job is far
Yeah,
more difficult. It's
right. So
far
the
more
actual
difficult.
the actual answer is simple. You just said it. We need a system based on primary care that is equitable for all. And the only way they're going to do it is to balance the payment system.
That's it.
Primary care physicians have to know the most, they have the biggest stress load, and we are the only field of medicine in population health that has been proven to increase and improve people's longevity. We meet the quintuple aim of healthcare. We deliver higher quality care at lower cost. It's relationships-based medicine where there's trust and communication. We base it on lifestyle medicine, less drugs, more prevention, and we'll have a better place. It's simple. We could save the medical industrial complex and the entire fee trillions of dollars, trillions, but nobody wants to do it because it's such a big business that people are making money on. So, part of me says the answer is real simple, and the answer is real simple, but can we make it happen? The
Right.
only way is with advocacy.
And we don't, and we as a primary care group of doctors have no lobbyists in Congress. We're
Yeah.
terrible. And we've done a terrible job. The dermatologists, you could read their story in our book, how they invented different diseases and now we're among the highest paid doctors with the lowest workload. We are the lowest paid doctors with the highest workload. That has to change. And the two thing that you just brought up from your TV experience is that drug companies have to be shut down in terms of their ability, A, to advertise. We're only one of two countries that allows that. Two, their ability to advocate in Congress. Three, their ability to pay for medical studies and medical research and create protocols. They have to be removed from all that. And they have to just sell their stupid drugs. And if the drugs are good, we don't need advertisements for them.
Yeah.
Give us a good drug, we'll use it. But we don't need you to impact Congress. We don't need you to create the protocols. And God knows, because I'm Alan and I write articles, and I'm writing one now. And I looked up the Cochrane review of the articles, and they said 21 of these 27 articles are sponsored by drug companies. And this is what we're seeing. And so already I don't believe the article because I
Yeah.
know it's been manipulated. They have to get out of there. So
We need to
just
blow
those
up the
things.
medical industrial complex. It needs to be blown up, and we need a fair and equitable system based on primary care with more primary care providers and less specialists and less things doing to people and more for people.
And that's what we need. And it's easy. Couple steps and we could do it. We lay it out in what, 1 or 2 pages in the
Yeah.
book. It's really not hard, but like you say, there's a lot of people making a lot of money by hurting people.
Yep.
And that
Agree.
and that and that is that harming people is kind of like become the business model of the whole system. And we are the ones who get in the way of that. They don't want a lot of us. So anyway, Alan, we will keep helping people as much as we can in our own microenvironments, but it's becoming difficult
Yep.
to
It
keep
is.
going.
We
Okay,
keep plugging on.
have a good.
Hopefully, we will not become extinct.
We will eventually, and then we will not be replaced. So, unfortunately, but we'll keep pushing. So that's what we do. Have a
Take care,
great
everybody.
Sunday. Bye.